So good afternoon. This time in China is 17:30 afternoon, and we are about to present a transurethral thulium laser enucleation of prostate uh, ThuLEP by Professor Chao. Chao is from Peking University First Hospital, and he's very good at the endoscopic surgery for benign prostatic hyperplasia, and he's associate chief urologist and a committee member of Urology Branch, China Association of Medical Equipment, and with a lot of titles. And he also served as the head of collaborating institution on the National Natural Science Foundation at China and General Program Project. And also, he had won a national champion 2023 BPH category with the sixth national laser surgery competition. So today, the patient is a 61-year-old male. And would you please, his chief complaint is frequent urination and dysuria for more than 3 years, and has a past history of appendectomy 40 years ago. And his symptoms is mainly frequent urination dysuria with significant difficulty in urination at night, and nocturia 2 to 3 times per night. And he has been treated with doxycycline with apirized steroid, a, a Chinese-made medicine very similar to finasteride, I mean another type of 5-ARI. And the ultrasound showed he has prostatic cyst with post-void residue urine 10 cc. Oh, and also the blood test, the PSA is 2.3, which is normal. And the ultrasound showed his prostate is about 91 cc and also protruding into the bladder by 3.14 centimeter with heterogeneous echo texture and with normal kidneys, ureters, and bladder. So now we are waiting for the presentation of this thulium laser enucleation of prostate. And should I introduce my co-moderator, Dr. Santosh Bhugbati from South Africa, and his specialist urologist, and also the trained in ThuLEP in 2014. I was told he has done more than 800 cases of ThuLEP. Hello, Dr. Santosh.
Good morning, or is it evening?
Yeah. For you, it's good morning. For me, it's good afternoon. Okay.
Thanks for the introduction. Yes, that is correct. I do a lot of ThuLEPs and teach enucleation by ThuLEP and ThuLEP enucleation in our country.
OK， 好，可以切。OK, can you hear me? Professor Yuan and
it's very clear,
Professor
Dr. Zuo.
Yeah, OK. Nice to meet you and good afternoon, professors. I'm Dr. Zuo Chao, and today I will perform a ThuLEP laser. We can see the prostate and the prostate value is 94 cc or milliliter. We can see a big middle lobe.
You can see a big medium lobe.
Yes, and this we can see the orifice.
The urethral orifice.
Yes.
This is the right side.
Yes, you're right. Okay, we will start. And
so would you please introduce your protocol of surgery step by step, okay?
Okay, no problem. And I will introduce our first. I will introduce our equipment and instrument. The laser machine. We use the thulium laser. Thulium laser. We call it 自由星, and made
Oh,
in China. Yeah,
I
made
can
in
trace
China.
it. The children is a freestyle.
Yeah, yeah,
A
you're right.
freestyle in the sky.
Yeah, freestyle. And uh, our equipment, our laser machine setting, our setting is a super pulse, and uh, 1.5 joules and 55 volt, and we can see the surgical
Surgical, yeah, safety
capsule.
gap
Yeah,
beneath the surgical capsule. So,
around the very mountain arm, we see it's easier to reach the capsule. And our surgical planning, we usually performed earlier apical release and U-shape. Yes, U-shape in block
yeah.
enucleation.
So
The
you
first
will
is
do an
yes,
en bloc
yes, en bloc.
enucleation of the
Yes,
prostate.
yes, and we can see the left lab. Uh, we use the cutting and the magnetic
Mhm.
method to reach the reach the capsule. We can see here we must calculation point to point.
Do you do any form of early apical release as a standard?
Sorry.
The standard form of the apical release.
Do
Yes,
you
呃，
do you
yes,
do that
就是您
routinely?
肩部离断的有那个标准的方式吗？
uh, yes. We have normal apical release, and from this step we can see it. One step, the first step, we around the very mountain arm, we can reach the capsule, surgical capsule, and we can see the red lobe. From the red lobe, from the 6 o'clock to
嗯
the 12 o'clock,
嗯。
we can see we can back the scope and sorry.
And Dr. Santosh, when you do the HOLIP, how
Mhm.
can you reach the gap beneath the surgical capsule? Is it the same technique or
I use a
something different?
similar technique. I know that there are a few techniques described. I tend to use unblock technique. I use that routinely for all cases. I do the same, these hockey stick incisions under each lateral lobe. I normally find the plane under each lateral lobe and I join them across the midline. So that at that point, you've got a plane under each lateral lobe and under the median lobe. And at that point, I mark off the 12 o'clock area. I also find the plane at 12 and then use those 3 points to do an early apical release. So that's what I use. And I normally use a top-down technique. So once I've found these points, I normally work mostly at 12 o'clock downwards on each side. Yeah. And yourself, what technique do you normally employ?
So I agree with you. This we often do the same, almost the same technique. So if you do an enucleation for a small prostate, something like 30 cc, sometimes it's very difficult to find the surface beneath the surgical capsule. Do you have any idea for these cases?
I I there are a few things. I make sure, firstly, that it is BPH, that is an adenoma that we are nucleating, and it's not just a high bladder neck that you need to just incise. But if you're talking about a BPH gland with an adenoma of about 30 cc's, I employ the same technique, but I am a little slower and I use lower power to enter that area. I do twist the scope and I make sure that I do see the lateral lobe lift on each side. So I limit the dissection under each lateral lobe initially. I then proceed from the top down. So with a smaller gland, I do leave the 12 o'clock strip of mucosa intact. So I make incisions down around the apex, starting from, well, one incision at 11 and one at 1. So the 12 o'clock area of mucosa is left intact. I think that does help with reducing incontinence. So I make those incisions at 12, at 11 and 1. And I find it quite easy actually to get to the correct depth and then follow it down and around the prostate. Um, I think that's one of the things I insist on with the smaller gland. I try not to remove I try to leave a strip of mucosa. I think for two reasons. One is the continence, and secondly, bladder neck stenosis is a real noticeable. It's a significant complication in the smaller gland. That's more common in the smaller gland. And I think there's evidence that if you leave some mucosal strip intact, it does reduce that um, degree of stenosis or the incidence of stenosis.
That's a good idea to remain 12 o'clock mucosa intact to prevent bladder neck necrosis, stenosis.
Mhm. I think I think they are dissecting the 12 o'clock area right now. So,
Yeah. For big prostate, the
mhm.
incidence of bladder neck stenosis is much lower.
Yes, yes. I think I think you would see strictures more commonly. I suppose these are complications with any whole, they're possible complications. The transient urinary incontinence, bladder neck stenosis, strictures, injuries to the ureteric orifices or the sphincter. So those things can happen. But I think with the larger prostates, because of the time spent in the urethra and the amount of traction you put on the sphincter, I think with the bigger prostates, I see a bit more incontinence and strictures more commonly. I don't really see bladder neck stenosis in the larger prostates. Yeah, following HOLEP in a larger prostate. With the larger prostate, I do start at approximately the level of the veru distally, so at the apex of the gland. I do make sure that we mark that 12 o'clock area. And I try to do that as opposed to what a lot of other whole lip surgeons do. A lot of whole lip surgeons make a vertical incision from the bladder neck downwards at 12. I actually try to make a little horizontal incision near the apex. And I widen that horizontal incision to reach the level of the capsule. I think for the beginner, it's interesting. I just found that a lot of new whole hip surgeons tend to find the capsule a lot more easily at 12 if they follow it horizontally and they don't actually end up perforating the capsule. I think with experience, we probably won't perforate, but the surgeon embarking on his whole hip journey, for me, that's one of the tips and tricks to avoid perfing the capsule.
Yes, I agree with you. For beginners, we often do a vertical incision to reach the capsule. We enucleate the prostate at two parts, left side and right side, not a unblock. It's easier
Okay.
and it's more convenient to find the right surface or the right position.
Yeah, I agree. I I've had different experiences with different trainees. I've had some trainees that take to the en bloc COLEP very easily, and they prefer that from the very start. And then there are others who prefer the doing it in three lobes or two lobes.
Yeah,
I don't think there's a
sometimes
right and wrong answer.
um,
Um,
the three lobe
Personally,
technique.
I find it very, I can't find a reason to go back to a two or three lobe HOLEP. It's very rare that I actually think of doing that. Um, I think the advantages of an en bloc procedure, once you've gotten the technique right, are that you just really do need to find the plane once, and then you can follow it around.
Mm,
You don't need to find the plane more than once. I find that there's less bleeding because you're not cutting into the gland.
mm,
And for me, it's faster. It's
mm.
faster that you just get around it and proceed.
Yeah.
Do you normally do an en bloc
It
enucleation?
depends. If the prostate is not very big, less than 100 cc, I'll prefer to do an unblock enucleation. For very large prostate, sometimes we may do a two lobes and even three lobes technique for safety. And also for a big prostate, you need to have a good modulator.
Oh, yes. What kind of what modulator do you use in practice?
We use the Raykeen modulator
Okay.
accompanied by the thulium laser equipment. It's more convenient with better efficacy to uh, remove all the tissues.
And I know there are principles of morpholation that we may take for granted, but for
Mm,
the aspiring whole surgeon, they are, I suppose, you will see our surgeon follow these rules. You should have excellent hemostasis before commencing your morpholation. So you should have hemostasis, which means that you will have good vision.
mm.
You should be able to see what you are
Yeah,
morpholating.
we
And
we need to remain a good vision and try to
mhm,
avoid the damage of bladder.
mhm. I also keep the tip of the modulator a few centimeters away from the tip of the scope so that you can see past the specimen, past the prostate on either side of the specimen, between the specimen and the modulator. You should be able to see some darkness on either side.
Mm.
Um, I sometimes I do morpholate in the bladder at most times, but if it's a smaller gland or if it's something that's bouncing around, I tend to apply the suction and bring it back to the fossa if the fossa is significant, and then I just morpholate in the fossa. If it pops up off the morpholator, I do adjust the settings, but it tends to bounce back down onto the morpholator. It's something that I find convenient.
Yeah,
Um,
we
but I
sometimes
think.
uh, suck the prostate into the fossa for modulation. It's
Mhm.
uh, much safer.
Yes, yes.
And Dr. Zuo Chao, which kind of modulator will you use?
I've used three
Modulator,
different
modulator we use
modulators.
the Raykeen 风云. Yeah,
So Dr. Zuo Chao will use the Raykeen modulator
yes.
um, uh, next.
And for the for the big prostate, for example, more than 300, 300 we don't modulator. We just use the open surgery to
To remove the whole
get the
whole
tissue. Yeah,
prostate, a small
yeah,
incision in the abdomen.
yes,
It's more convenient with very short time. Yeah.
yes. You are right.
Mm.
Do you have any tips for the really large prostate? Is there anything that you do differently?
So we have a different technique for very large prostate, something like more than
Mhm.
200 cc. Some doctors
Yeah.
will perform a laparoscopic enucleation for the prostate via the bladder, or even in very rare
没
cases,
水了吗？
open surgery.
哦，有，没关系没关系，是我这儿堵了。
But in the past 10 years, I have not done any open surgeries for a prostate enlargement. For patients with very large prostate and sometimes with big bladder stones, we will use a small incision on the bladder to remove the stones and the prostate tissue.
Yes, I agree with you.
And do you still send those patients home quite early with a catheter?
So you mean the duration of the catheterization?
Yes, and the hospital stay and the catheterization.
You mean the hospital stay and cath. So Dr. Zhuo Chao, will you introduce uh, the days for catheterization and hospitalization?
Sorry, I can't hear.
就是您这个手术以后，大概导尿管放几天，住
Oh,
院几天？
yeah, 3 days, 2 or 3 days. Uh, it is up to the caster color.
So 2 or 3 days for catheterization.
Yes,
Uh, depends on the color of the urine.
yes. 住院一般是hospital whole stay just 5 days.
So totally 5 days for hospitalization.
Okay.
So in my
Is this
hospital, patient will discharge 1 or 2 days after the surgery, uh, according to the color of urine and also the age and the general condition of the patient.
an academic unit or a private clinic that you work at?
Sorry, I cannot hear you very clearly.
So he was asking about the setting. Is it this is an academic? Is this an academic hospital that the surgeries are performed at?
You mean academic
Um,
or uh,
I think our healthcare system is a bit different. So my whole labs are generally performed in a private clinic, a private hospital. So we do have to motivate for if the patient does stay for a longer stay.
mm,
Um, I normally discharge the patients. We normally do them, well, we try to discharge patients within 24 hours.
you will
Um,
discharge within 24 hours?
yes,
Uh,
we discharge most patients within 24 hours, but the catheter is variable. I think there is a bit of hematuria. I leave it for an extra 2 days. They are discharged with the catheter and a leg bag, and we bring them back to my clinic or room and have them removed
so your
as an outpatient.
hospitalization is short. This depends on the economic condition and
Yes,
also the
yes.
regulations for the insurance, I think.
That's correct. That's correct.
I think Dr. Zhou has enucleated the whole prostate, uh, but we need to do some hemostasis. Mm, mm, mm.
With the really large prostate, I try to make sure the bleeders at 12 o'clock on the anterior surface of the fossa are taken care of before completing the enucleation. Because with a really large prostate, that area tends to drift away from you once the prostate's in the bladder. So I don't
Yeah,
know if you find the same, but and then with a straight fiber, it's difficult to reach it. Unlike a loop, which you can sometimes push out towards the surface. I just find it difficult to reach these bleeders once the prostate's gone.
that's a really important suggestion for
Yeah.
the 12 o'clock area. If some residue gland, it will go up and very difficult to resect it by the laser fiber. So sometimes we have to use the loop, the TURP loop, to reach it. But nowadays, once we incise the 12 o'clock, we will try to avoid this situation. Mm,
Correct.
帮我接一下粉碎器，开，
mm.
分数调
Is
到
there a
3。
reason why you prefer thulium fiber as opposed to continuous thulium or holmium YAG?
Uh, in my hospital, we do both and thulium laser enucleation, um, but mostly thulium laser. It's easy for hemostasis and for small prostate. Sometimes, if we have some difficulty in reach the gap beneath surgical capsule, you can do a resection. Mm,
It's quite a beautiful enucleation.
Thank you.
Thank
And I find the plating.
mm, 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 mm. So one big advantage for thulium laser is its good ability for hemostasis. We need a clear vision for methylation.
Yes, you are right. I think modulation have two simples: the the clear vision and the full water of bladder.
Mm, yeah. So good vision with plenty of irrigation. That's very important for methylation.
Yes,
you.
Mm,
And that's the point where the floor nurse becomes the hero in this case, because the floor nurse needs to be well trained and they do need to be well aware of what's going on, and they are the ones who need to manage the fluid while we are morcellating. So I always make sure that we don't have somebody new who doesn't know the procedure managing the fluid. I think that's almost as important as having a well-trained surgeon. I think your staff around you need to be well aware of the steps involved in this procedure.
Oh. Mm. Mm. This prostate has a lot of supply,
Yes,
so
yes.
uh, so you need some time for hemostasis.
好的。为什么一直有出血的地儿呢？
Mm. 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 So active bleedings are often located at around 12 o'clock or near the verumontanum. So, Dr. Zuo, would you please introduce the parameters of your enucleation and hemostasis? I mean, the
呃
engine.
yeah, the hemostasis for by using the ThuLEP laser, we think the best way is to point to point. We must find the bleeding, and the other the second one we must we can see the blood circle. This circle we must bleed enough, stop
Right.
bleeding enough, and
Bladder mucosa around the bladder neck is very easy
yes,
to have some hemorrhage.
yes, you're right.
Mm.
And for the vein bleeding, we think it doesn't matter. We can use the catheter to brush it.
Mm. Yes, for the bleeding inside the fossa, the catheter can press it, but not the bladder neck. Mm.
Okay.
So years ago, with old style modulator, sometimes the duration of modulation is even longer than the nucleation of the prostate.
Hmm. I think with a really large prostate, it still is the case that the morcellation can take a lot longer than the enucleation.
Yeah.
If the
But for
gland
new
enucleates,
generation of modulator, this is very rare. You can see the efficacy of this modulation is much quicker.
Yes, all right. I prefer to this modulator machine. I think it's very, very efficient too.
Mm. Mm. It's powerful, but we have to avoid bladder damage. So should be very careful
Yes,
with
you are
good
right.
vision.
Yeah.
Mhm. Mm. Mhm. Mhm.
转速给我调到2。
Mm. Mm.
I call this the boring part of the operation because there isn't any real surgical skill that can make this go faster. I think you are at the mercy of your modulator. Unless it's bouncing off, I suppose in those situations you can adjust your settings, check your suction, adjust the position of the gland, move it into the fossa, for example. But otherwise, if it is just a large
这个感觉
gland,
吸力不好
there's not much you can
啊，
do
没
to
关系，
speed
没
it
关系。
up, I suppose.
嗯
把转速调到1。对，
And when the gland tends to bounce off the modulator, if your suction is intact and high, you would need to decrease the speed of the modulator.
Yeah.
So,
So Dr.
yes.
Zhuo has
Mm.
reduced the speed of modulator and
Yes，
tried to grasp the residue tissue better.
round is too high, and the round setting is I know is 500, 350 50 round 1 minute.
嗯嗯
再给我换一个线气头，这线气头觉得有问题呢。线气头看杆
And, if the
Yeah, it's good.
gland is not modulating, if you can't suction, I My steps are normally check if the suction is still on, and after that I disconnect the handpiece and listen for suction, and that can tell you whether there's a chip blocking the actual morcellated tube or whether the problem is elsewhere. We often keep a second set of blades next to me, and I swap blades while the nurse flushes the blade that was off. Um,
Mm. Mm. So Dr. Zhuo has pulled the tissue back into the prostate fossa
Yes.
for modulation.
A small space is better for the oscillator. The tissue it didn't
This is
will
good,
not.
good
Yes.
method for modulation for small tissue. Mm. They are easy to escape.
Yes.
yes. If I have a really small, solid nodule that keeps bouncing away, I use a three-prong grasper to just pick it up and take it out.
Yeah, I think almost
That's if it
done.
is quite solid. Mm.
A really
不
good
用不
job
用
for
了。
Dr. Chao.
Mm.
We can
Mm.
turn back the laser resector scope and for stops bleeding.
Mm. Mm. Uh, So for a prostate like this 94 cc, the whole
Yeah.
process is less than 1 hour. This
Yes.
is really splendid surgery.
I think initial
No.
studies mentioned that or state that ThuLEP or enucleation, ThuLEP
Mm.
or HOLEP,
We can see
one of the
the
disadvantages.
signature.
Sorry.
This is the
Mhm,
sphincter.
Yeah. It's no problem.
mhm.
And the sphincter is intact. Um,
Okay. I have done the surgery, the ThuLEP, and we will enter the catheter.
uh, so thank
And
you, Dr. Zhuo.
thank you, Professor
And
Yuan, and thank you, Professor
a
Torish.
perfect surgery. And
Yeah.
so, Dr. Santosh, do you have any comments on the surgery for Dr. Zhuo? And should you share your experience for HOLIP? We still have a few
I
minutes.
think I think that was a beautiful enucleation and just proves that why this should be the standard for the large prostate or why it has replaced open prostatectomy. One of the noticeable things that you just mentioned is that this did not take long. This took less than an hour end to end, and it is no longer a lengthy surgery, as you've seen. It's quite